Good morning, everybody. It's my great pleasure to introduce Dr. Meghan Lindstrom, who is going to be presenting Grand Rounds this morning, and tell you just a little bit about Meghan. She graduated from the University of Minnesota with a biochemistry major, summa cum laude, and Phi Beta Kappa. And what I didn't know was she had a minor in Asian languages and specializing in Japanese. And then she entered the University of Minnesota Medical School, where I had the pleasure of having her in my small pathology group, and first learned about her great interest and her great skill set in preparation for every single session of our pathology labs. And her interest in pathology grew over that year. We talked briefly about her joining us as a post-sophomore fellow, but her twin sister, Molly, and she wanted to stay together and graduate together through medical school. So ultimately, she didn't do that. And parenthetically, Molly was in Dr. Crossan's small group. And then when she was through her clerkships, we talked again, and she definitely had decided on pathology at that point. So she and Molly looked at various residencies, Molly in internal medicine and Meghan in pathology. But ultimately, it was our great joy that she matched with us as our first choice candidate. And during residency, she has similarly thrived, being the resident representative to the board of directors of the Minnesota Society of Pathologists, and publishing 2 papers with a third underway. So this morning, she's going to talk to us about her passion for her medical education with her Grand Rounds talk of the past, present, and future of pathology in medical education. So thank you, Meghan. We look forward to this.
And thank you so much, Dr. Powell, for that incredibly kind introduction. I really appreciate it. And good morning to everyone joining the talk. And got a lot to cover today, so we'll go ahead and get started. And I just want to mention I have no financial disclosures. This is a review of my objectives for this talk today. So first, kind of provide a brief review of the trends in undergraduate medical education and how pathology fits into those changing trends, which will provide us with a foundation to discuss some strategies to enhance exposure to pathology and pathology education in both undergraduate and graduate medical education. And then finally, we'll kind of summarize why I think increasing this exposure to pathology is important, especially for our non-pathologist clinician colleagues and clinical trainees. But before I get into the meat and potatoes of the discussion today, I wanted to provide kind of a brief overview of why I became so passionate about pathology education in undergraduate medical education. So when I entered medical school, I had basically no idea what pathology was. I had no idea what it took to become a pathologist. I didn't even know that pathologists were medical doctors. And I was convinced that I was going to do, like my sister, an internal medicine residency, and then I would proceed to do a hem-onc fellowship. However, by the end of my first year of medical school, kind of right in the middle of my first introductory pathology course, a light bulb kind of went off in my head, and I realized pathology is where I am meant to be. And so fairly early on, then in my second year of medical school, that's when I really became more committed to pursuing pathology residency and training. And so having this perspective and knowing that I wanted to be a pathologist then allowed me, once I started my clinical clerkships as a third-year medical student, allowed me to really approach those experiences from the perspective of future pathologist. And so when I was working with the clinical trainees and my clinical attendings and mentors, I really tried to pay attention to their workflow, how they interacted with the laboratory medicine and pathology services, so that I could glean as much as possible from them and from those experiences, so that I could really anticipate what their expectations and what their most common questions would be of me in the future as one of their pathologist colleagues. And my ability to kind of understand what it would mean to be a pathologist was really greatly enhanced by the fact that I had the opportunity as a medical student here to rotate in several pathology electives. However, throughout the course of my clinical experiences, there were a lot of kind of patient care moments that stood out to me that made me kind of think about what our pathology education and undergraduate medical education really does for our clinical colleagues, and how it prepares them to be the best clinicians. And so, I really started to question the efficacy of our pathology education structure and undergraduate medical education when, multiple times as a medical student, when I was rotating on the wards, even as a medical student, if we had patients and family members who were really anxious about biopsy results, I was often the only member of the clinical team who could answer questions about, what happened after the tissue was collected, where was it, what was happening to it, how long would it take to get a report out. And no one else that I was really working with, and none of my senior residents or attendings could answer questions and describe those processes involved. And I was also really surprised when I rotated on surgical services that had heavy utilization of blood products and transfusion medicine services. When the clinicians and even the clinical trainees and even the attendings found out that I had done a rotation in transfusion medicine, they started asking me a lot of questions about blood banking practices and orders. And actually, one of the most common questions that I got was, what is the difference between a type and screen and a type and cross order? Despite the fact that, these were very capable, very competent clinical trainees and attendings, and very, very good and efficient in managing even the most complex of the patient cases. They despite the fact that they interact very frequently with the laboratory system, they didn't really have a good understanding of kind of the underlying processes involved and what happened after they placed an order in the patient chart. And so that really inspired me to do not only reflect a little bit more on our education system in medical school, but also inspired me to learn a little bit more about how our undergraduate medical education system is structured, and kind of how pathology fits into that structure. And so, when I think about pathology and undergraduate medical education, the kind of prototypical structure that I think of is, a core, pathology as a topic is more kind of focused on pathobiology and the pathologic basis of disease. And so it's much more heavily rooted in undergraduate medical education in basic sciences and kind of foundational topics, and not so much as a clinical practice. And so, the complexities of what we do on a day-to-day basis and how we use the basic sciences and that foundational knowledge to provide information and help drive clinical decision-making, a lot of that is lost and not conveyed in introductory pathology courses in undergraduate medical education. And, how pathology is able to be conveyed as a topic in a field in undergraduate medical education has been changing a lot recently. And so I kind of wanted to touch on some of these trends. And so a lot of the changes that we're seeing now emerging in undergraduate medical education stem from changes in accreditation standards that were made in 2015 by the LCME. And so prior to 2015, a lot of the accreditation standards were much more rigid and kind of ended up essentially stipulating that medical schools would require standalone courses in some of these foundational topics like histology, pathology, biochemistry, genetics, physiology. in order to meet specific education objectives. However, in 2015, these accreditation standards became much less prescriptive and much less descriptive, which gave medical schools a lot more wiggle room, essentially, when designing their curricula. So it comes as no surprise that shortly after that change, a lot of medical schools started changing their curriculum and how they approach medical education for their students. And on the right-hand side here, we have kind of a summary of findings with respect to changes in medical school curricula provided by the American Association of Medical Colleges from 2017 to 2018. And of the medical schools surveyed, only 16% of those medical schools had stable curricula. The remainder of medical schools were either in the process of changing, implementing changes, or had already implemented changes to their curriculum. And a lot of the changes that were happening were focused in preclinical clerkship education. And kind of as an aside, this is also changing, and these changes are also being made in concert with changes in the USMLE boards, particularly with respect to the reporting of the results of those examinations. Some of the structural changes and some of the major structural changes that were being made at the time and that are still being made have resulted in much stronger emphasis being placed on clinical experiences and clinical clerkships. And so the overarching theme has been to expand clinical experiences, which then results, of course, in shortening of pre-clerkship kind of classroom-based training. And so the majority of medical schools at this point in time have reduced their pre-clerkship training to between about 1 to 1.5 years. And here at the University of Minnesota, we're sitting at about 1.5 years. And so, this has drastically shortened the amount of quote unquote classroom-based learning time that is available in undergraduate medical education to prepare future clinical trainees for their clinical clerkships. And pathology has generally been relegated to that kind of foundational material that's focused on into the pre-clerkship training. And so this kind of shortening of pre-clerkship training phase has also therefore resulted in a reduction in the exposure of pathology in undergraduate medical education. There's also been a very large push for integrating curricula. So instead of having a lot of standalone courses like histology and pathology, there is instead a kind of short period generally of kind of a summary of like foundational topics, and then medical schools transition into organ system-based education. And again, this kind of reduces the amount of time for individual topics like pathology to be taught. And as we all know, especially with the COVID pandemic and post-pandemic, there have been a lot of changes, not only in terms of content that's being taught, but also how that content is being delivered to students has changed drastically. So there's been an increase in virtual and digital resources as well as sessions, which has also resulted in reduced exposure to in-person experiences, including laboratory sessions and microscopy sessions. And overall, how these changes are impacting medical education as a whole is fairly difficult to assess, not only because these changes are essentially constant, they keep happening, and so it's kind of difficult to establish a baseline, but the results that have been generated so far kind of show a mixed picture. So some studies show that with the increase in digital resources, in particular, some students report increased engagement and increased satisfaction with having those resources. In particular, also having access to kind of like student-driven educational opportunities and self-directed learning. While there are other studies that have shown a concern for decreased student performance overall, including a University of Michigan study in which the percentage of students performing at a substandard level on like basic histology items and examinations increased 15-fold, and only 15% of their student population was assessed as performing at an adequate level. And then also looking at the trends in the USMLE performance, there's been kind of a steady decline, a small but steady decline in the percentage of students passing the board exams on their first attempt over the last several years. And so this has kind of raised a little bit of concern. But overall, an overarching theme in terms of how these changes are impacting undergraduate medical education is a little bit unclear. In terms of increasing exposure to pathology and giving pathology a little bit more of a footprint in the pre-clerkship training, one of the other, the fact that it's always been kind of historically maintained in that kind of pre-clerkship phase. In addition to that kind of historic treatment of pathology, the USMLE board exams kind of further support medical schools in kind of limiting motivations to increase the pathology footprint in the pre-clerkship training phase. So on the right-hand side of the screen is just a couple of screenshots, essentially, of the content breakdown and disciplines that are assessed as part of the USMLE board exams. And despite the fact that they indicate that about, the majority of their items on step one are pathology based, we all know that, the focus of pathology on these exams is really more focusing on basic pathobiology and histology, and it's not really representative of pathology as a clinical discipline. And then, of course, step 2 and step 3 really don't even mention pathology as a discipline or a competency that is being assessed. And so in structuring their exams this way, it essentially kind of sets up the expectation that pathology is a non-clinical field that's focused primarily on basic sciences, and really de-emphasizes the clinical competencies and the clinical reasoning skills that we need to be, high functioning, efficient and effective practicing pathologists. So overall, kind of the persistent issue with like the USMLE board exams and how they recognize pathology in conjunction with the kind of recent changes in undergraduate medical education curricular structures have kind of raised several concerns about pathology in undergraduate medical education and how efficacious it can be in terms of preparing future clinicians, how to interact effectively with the lab and navigate diagnostic complexities and challenges in managing patient care-related issues. And so some of these concerns include, there's an obvious reduction in medical student exposure to pathology material, and also kind of isolating pathology only to pre-clerkship education means that there's really no longitudinal exposure. And so some of the complexities of integrating basic pathobiology and diagnostic skills can be lost with advanced clinical clerkship training without that persistent exposure. Obviously, a reduction in pathology material and exposure in undergraduate medical education means that students may not have as much exposure to working with pathologists. And so the opportunity to form, personal relationships and mentors with pathologists to inspire trainees to consider pathology, and also to inspire them to continue to collaborate with pathologists once they get on the wards, those opportunities are significantly reduced. Kind of mentioned this already, especially with the USMLE exams, that the focus of pathology education is really on more, I should say, in undergraduate medical education, is focused more on basic sciences and not on the practice of pathology and pathology as a clinical service, which means that a lot of medical students are not really learning that about what pathologists do and who they are and how they can actually help clinicians interpret challenging data and use that data to drive clinical care decisions. And, especially with reduced exposure to pathologists and pathology in medical education, one of the concerns that I think about is that, they won't incorporate us much or consult us when there's a challenging issue that arises, and they'll instead stick to the resources with which they're familiar, which will often be their own clinical colleagues. And so, it's a natural tendency when we're faced with a problem, we tend to utilize resources with which we're familiar instead of reaching out to and using resources that are more novel. And so it's really important that clinical trainees understand pathology as a clinical service, and not just basic sciences, um, uh, in order to achieve that aim, to encourage them to reach out to us and ask us for help in clinical situations, when there are diagnostic questions involving laboratory studies. And, I think it's easy for all of us to say that undergraduate medical education really does not prepare trainees to be pathologists. And I'm not saying that it should, but certainly undergraduate medical education should teach trainees how to optimally utilize all of their resources, including their clinical colleagues, and that includes pathologists. And right now, with the kind of reduced exposure and the trend in kind of continued reduction in exposure to pathology, I question whether or not, this point is really being addressed by our current medical school system. And so this has really made me think about the necessity of alternative education options in order to ensure that clinical trainees and our future clinical colleagues get adequate exposure to pathology, not only as a diagnostic specialty, but also as a clinical discipline, so that when they have issues that arise in the future when they're managing their patients, they feel comfortable and confident reaching out to us to ask us for help when we can be of help. And so I really started to consider how can we kind of bridge this gap and this ever widening gap between clinical and diagnostic specialties. And so that kind of, as I entered residency, that was one of the things that I was thinking about. And so I started really thinking about creating a series of lectures or some sort of program that would allow clinical trainees and trainees in pathology to interact, and especially for the pathology trainees to convey and provide that information that was missing from undergraduate medical education in terms of, not in terms of essentially introducing pathology as a functional clinical service. And so thinking about who would best be targeted by this program, and kind of starting off introducing this program to non-pathology trainees, I thought about starting this program with either internal medicine or general surgery, essentially simply because those services have a very broad exposure. They're larger services. They have a lot of patients, and they cover kind of the most general disease processes. And so learning about pathology and laboratory services and diagnostic specialties, I think, would be a really high yield for these services because they are involved in so many different aspects of patient care. And then if this program was successful in one of these programs, then it could potentially be more easily expanded in terms of reach to other programs, other training programs. And so I had some relatively recent experiences as a medical student prior to my residency program, working with some of the chief residents as well as the program administration and internal medicine. And so I kind of focused on working with the internal medicine team to kind of trial this program. And so I really started to talk more with the internal medicine chief residents as well as kind of then assistant program directors about establishing a program like this after I had started attending more regularly their internal medicine morbidity and mortality conference, and especially after I started presenting some cases at that conference, with those presentations being well received. And one of the things that I focused on in those presentations was not just explaining the morphologic features of the specimens that they wanted to review, but I really wanted to take the time to explore and detail more the methodologic approaches to the interpretation of those specimens to provide additional education with respect to like how a pathologist thinks and how we work through problem solving and diagnosis. And so, after establishing these communications with the internal medicine team about this program, and looking for ways to enhance learning opportunities for their trainees through these clinical conferences, I started to kind of push a little bit more for starting this sort of bridging program. to give them more focused exposure to kind of functional pathology and pathology as a clinical service and clinical resource for them. And so to start building these sessions, to make sure that these sessions would be of high yield for them and something that they would be interested in repeating, I made sure that, I would focus these sessions on areas of pathology that they thought would be of greatest interest to them. And so the sessions, and every year that I start these sessions over again, I get kind of the same triage of topics, which is clinical chemistries, blood banking and transfusion medicine, and surgical pathology and cytopathology. And I've listed here the attendings that I've collaborated with while designing these various sessions for presentation. And the overarching theme, again, of these presentations is not to teach clinical trainees. And I make it very clear when I'm working with the clinicians, it's not to teach the clinical trainees how to be pathologists. It's really more about just teaching them about giving them information so that they can understand more about laboratory services and pathology services, or general workflows, so that we can really start to demystify the black box that is the lab. And so that they can have a better idea of, when they order a test and that specimen is collected, where does it go? What's happening to it at any one point in time before the result pops up in their patient's chart. And so to achieve this objective in these sessions, I really try to focus on providing like a basic overview of our services, our workflow, the staff and faculty that are involved on each service. And these sessions are given in person so that we don't only have the opportunity to give the clinical trainees kind of a list of names of who's who in the department and in our departments, but they have the opportunity to then also put faces to those names. And so it's really important that pathology residents, as well as pathology attendings, attend these sessions and lead these sessions to kind of increase visibility and increase kind of personal familiarity with our services. And these sessions, of course, the overall goal is to have them be interactive as well, so that the trainees are not simply sitting there, but they have the opportunity to ask questions, and those questions can open dialogues between our services, and also the trainees have the opportunity to address questions not only about theoretical approaches to cases, but also about real-time questions they have about patients that they're currently managing. So that's kind of just a brief overview of my approach to designing these sessions. And so now I wanted to give you kind of a cursory glance at what some of the materials for these sessions look like. And for these kind of examples of session materials, I pulled material from the sessions from which I actually have been able to collect some objective data. And those include my clinical chemistry session and then the surgical pathology and cytopathology session. This slide that I'm showing right here is a slide that I open all the sessions with to kind of explain pathology subspecialization, the number of fields that make up our one department, because this is something that's not necessarily taught a lot. And a lot of, anecdotally, a lot of the clinical trainees that I work with are kind of surprised by how many subspecialties there are in pathology. And this spectrum that I have here is by no means exhaustive in terms of describing all of the subspecialties within pathology, but I try to pull some of the primary specialties that the majority of clinical trainees will interact with, at least at some point in time during their training and practice. I also try to split up and indicate kind of this divide between anatomic pathology and clinical pathology. And I kind of simplify that breakdown for clinical trainees into a concept of solid pathology, where anatomic pathology, we're working obviously mostly with tissues, and clinical pathology is liquid pathology, where any sort of fluid that's taken out of their patient will generally end up being analyzed in the realms of clinical pathology. Now, I always point out that hematopathology kind of sits right in the middle. And then transfusion medicine is so far down the line of clinical pathology that it is essentially its own distinct clinical discipline. I also use an arrow to kind of indicate where on the spectrum will be for that session to kind of focus the attention and learning for those sessions. So for some of the materials that I have in the clinical chemistry session, I always start my sessions as well with a list of objectives. And those objectives, as you can see, kind of break down the presentation into kind of a general overview of the services, kind of laboratory processes, including kind of more clinically relevant topics. And then again, visibility for our staff and faculty so they understand a little bit more about who's in the lab, and if they call the lab, who can they talk to. And so for starting off with our service overview, these are some of the or screenshots of some of the slides that I include in kind of describing kind of what our clinical chemistry service is, what tests trainees can expect to see, and tests that they're probably at this point in time very familiar with ordering, and just kind of give them some information about our services, kind of what we do. In terms of laboratory processes, the slide has a lot of information, but I kind of go through it very briefly just so that they kind of they can have a better idea of kind of where specimens go and what's happening to specimens each step of the way, from collection to receipt in the lab, to loading the specimen onto analyzers, to reporting results in the patient's chart. I also give them a kind of brief overview of, when we say assay and test, what's actually being done to the specimen and how are those results being obtained. And of course, no discussion of that is complete without talking a little bit about our laboratory informatics system and how that information is taken from our own laboratory systems and then placed in the chart so that they have access to those results. Also kind of have a number of slides here that kind of go over, some kind of key concepts that they can apply when interpreting any result that they get back in a patient chart, including various types of quote unquote laboratory error, so that they can have some tools to start kind of thinking through results that they get, especially if they're ever concerned that a result doesn't quite fit with the clinical presentation of their patients. Of course, contacts, being familiar with and being comfortable with contacting the lab is one of the kind of main points of these sessions that I always emphasize. And so I, at each session, I always tell the trainees, if there's nothing else that you take away from these sessions, the one thing I want you to remember is that if you have a question about a lab result or a study, just call the lab. And so I will usually provide in these sessions, I will provide kind of like the general lab contact number. So for clinical chemistry, I provide the East Bank, West Bank core lab numbers, as well as the number for the CSC. I provide a breakdown as well with respect to when they call the lab, who can they expect to talk to, what can their kind of first contacts help them with, how can they help the trainees navigate kind of the phone tree through the lab. And ultimately, I also introduce the pathologist and pathology team, as well as fellows and residents who are on those services that can help answer clinical management questions. As for the surgical pathology and cytopathology session, one of the reasons why I was interested in doing this session is not only to explain a lot about really important specimen handling and triaging concerns, but one of the most frequent questions that I get with respect to surgical pathology and cytopathology from clinical trainees is there a difference between the two, and does it really matter which order I place? Now, obviously, as we all know, the answer is yes. So that's the primary reason why I wanted to put this session together for clinical colleagues. And so these are the objectives that I have, kind of, again, providing basic overview of services, kind of laboratory processes, as well as clinical utility. And then, of course, although it's not specifically mentioned here, but an introduction to kind of who we are and what we do, and how they can contact us in surgical pathology. So for kind of the overview of the services, kind of directly compare, surgical pathology and cytopathology in terms of what specimens would be received and analyzed by each service. I also provide, there's a lot of information, but it's kind of broken down individually on the slide as we go through this discussion so that clinical trainees can understand, we don't just get the tissue and in an hour have a result. There are very specific things that have to happen to that tissue in order to take it from the needle core or from the needle fragments to a slide that is interpretable. I also give them kind of an overview of our real-time assessment in both surgical pathology and cytopathology. For surgical pathology, obviously that involves frozen sections, and I try to provide them with an example that shows kind of what the difference is between frozen section processing and routine section processing. And then, of course, talk about rapid on-site evaluation, especially with respect to assessing specimen adequacy, particularly for ancillary studies. And no discussion about this type of field would be complete without discussing the limitation of how we preserve and fix our specimens, especially with respect to the importance of specimen triaging. If we put something in formalin, we're not going to be able to culture it. And so I like to drive that home, that if they have any questions whatsoever about how a specimen should be collected, how it should be handled, and how they should triage or set up the triage from a clinical perspective, they should call the lab to talk about that to make sure that they're able to get the most out of that specimen possible. Just in terms of basic navigability too, to understand how to get to our reports and our information that we provide them. I also provide kind of an overview of how to find pathology reports, as well as kind of the key components of the pathology reports, including, especially if they're interested in contacting someone who is involved in the case in order to get photos for a poster presentation, case report, or something like that. I like to point out how they can find who was involved in the case and recommend that they contact the trainees involved with the case. And then, of course, I always try to emphasize the comment section so that they know if there's some additional information that they're looking for, and additional guidance with respect to what they should do for next steps for that patient. They can often find, especially if the final diagnosis is somewhat ambiguous, they can always find that additional information in the comment section. In terms of assessing and giving them a general idea about interpretation of the specimens, one of the things that I wanted to convey between surgical pathology and cytopathology, obviously, is what we can actually say for each specimen, and kind of illustrate for them through the images what these specimens look like, and therefore what we can actually say about them. But one of the things I also really like to convey in these sessions too is that the process of diagnosis is obviously, as we all know, not black and white. There's a lot of shades of gray, and there are various degrees of uncertainty that we have to kind of grapple with, as well as convey in our reports to them. And so that's one of the things that I really wanted to do in this session. In this specific session is kind of approach more of like the art of pathology. And again, kind of emphasize specimen quality triaging and how that impacts our interpretation and final report that we can get to them. Again, emphasize contacts as well, who they can reach out to for whatever purpose. So initially, for these sessions, it took me about a year of communicating with the internal medicine program before I was able to have my first session with them. And so that first session was given in January 2023. We started with clinical chemistry with Dr. Colleen assisting in that. That session went over fairly well. There's a lot of interest in doing additional sessions. And so then we did multiple sessions focusing on various blood banking and transfusion medicine topics with Dr. Cohn assisting in those sessions. And so from those initial sessions that I gave, some of the feedback that I got and some of the feedback that I had for myself was to really provide more active learning, case-based learning to increase the value of these sessions. I also took this project and this program to Harvard Macy Institute to kind of workshop it and provide additional inspiration for ways to refine the program and expand the program. And then kind of started revising the sessions to start again with a different kind of approach to the sessions. And so one of the main things that I changed was I added specific case-based learning. So there's a clinical case, at least one clinical case that was introduced And these cases were often based on real cases that I had experience working with. And so for clinical chemistry, I introduced a case of HLH, using kind of the progression through the case to provide opportunities for large and small group discussion amongst the clinical trainees, and then allowing them to kind of discuss, how they would approach the case, how they would kind of structure the differential diagnosis. And then, of course, I would provide opportunities throughout the case presentation where eventually they would get stuck and realize, they could have a lot of options that they could go through, but eventually they would have to call the lab in order to figure out what the next best step would be for the management of those patients. In the surgical pathology and cytopathology session, again, provided a couple of different patient presentations. In this case, it's focusing more on diagnosing or ruling out cancer. And so, again, provided room for group-based discussion, progression through the case kind of naturally as they would if these patients were sitting in front of them. Ultimately prompting them to think about obtaining biopsies, what type of biopsies, and how to manage and interpret that tissue. I also provide, kind of at the conclusion of the case, some examples of kind of fictional reports, and emphasize the degree of uncertainty, particularly with respect to the site of origin of a tumor based on staining and morphology. And emphasize that, if they want additional information, it would be important for them to reach out to the pathologist, especially for consideration of ancillary studies. Initially, so I think one of the important things too that I started to think about as I went through this program and presenting these sessions is how to assess the effectiveness of these sessions. So initially, my whole goal was just to basically start this and establish these sessions and see how they went. And so I didn't really have any standardized method for receiving feedback or quantifying feedback. And so a lot of the feedback that I got was mostly anecdotal. But what I heard from clinical trainees about these sessions is that they, some of the things I heard was that they never realized that there were pathologists behind all aspects of laboratory testing, including like the chemistry lab. They didn't know that pathologists were available for them 24/7 if they had questions about lab interpretation. And, some of them, a lot of them expressed that the exposure to the sessions made them feel a lot more confident and a lot more knowledgeable with respect to what they could expect if they called the lab. And one trainee actually told me that immediately after attending the clinical chemistry session, when they returned to their clinical duties, they immediately called the lab to ask for advice and figure out what time would be the most optimal for collection of a lab to assess a patient's status. I think it was about anticoagulation or something like that. And so that was really impactful for me. And I realized that I needed more objective measures and more consistent measures for kind of figuring out how these sessions were actually performing. And so I designed pre and post-session surveys with the survey items kind of assessing a broad range of topics, including obviously basic demographics, the previous exposure to pathology that these clinical trainees had, their basic knowledge of pathology, how familiar were they with our department, with our services, and how likely were they to interact with the lab and consult the lab directly. For these surveys, I initially considered Google Forms, but one of the reasons why I shied away from using Google Forms, despite the fact that it has a really friendly user interface, is that participants need a U of M email access and an actual link, which they would have to type into their smartphones in order to access that. And so I ended up going with Qualtrics simply because it has, while the user interface is a little bit more complex, it's a little bit more customizable as well. And you can actually generate QR codes, which can be, you can have pretty general access for those QR codes. And so they could be really easily accessed by any trainee with a smartphone that has a camera. And they did not need to open a link, type in a link, or be signed into their U of M Gmail accounts in order to access those surveys. So I ended up going with Qualtrics. I just wanted to provide a couple of screenshots of what some of my survey items look like. Again, the whole goal is to kind of assess kind of prior knowledge of pathology, how they interact with pathology, how likely they are to interact with pathology. And I even included some items that would assess kind of their pre and post session likelihood of performing a number of different actions, including interacting with the lab. And so those were kind of some of the pre-session surveys, and then post-session. Again, really wanted to kind of assess changes in those behaviors, changes in perception of pathology, and changes in the likelihood of contacting the lab and viewing the lab as a valuable clinical resource. So the next several slides kind of have preliminary results from some of the surveys that I've been able to administer with these sessions thus far. And when looking at the data, one of the things that stood out to me is that the vast majority of trainees really reported no previous exposure working with pathologists or learning from pathologists directly. I do want to call your attention to the number of surveys or the number of survey responses that we're working with here. It's very small. I'd expect about 15 to 20 responses per session. Didn't quite achieve that. So that's something that I'm working on. Another metric too that I wanted to look at here is how likely or how frequently clinical trainees, their colleagues and their attendings, their mentors are interacting and consulting the lab. And you can see that the responses here trended toward the essentially sometimes, mostly, and frequently, and to the never options here. I also wanted to assess in pre-session kind of what their preferences with respect to resources were when they encountered clinical management questions that involved the lab. The vast majority of them, as I sort of anticipated, stuck with their familiar resources that they were used to, including their direct colleagues, their mentors, their seniors. Kind of a small proportion indicated that they prefer to use kind of text-based, resource-based, things like UpToDate. And then the vast majority said that they would contact the lab directly if they had questions pertaining to lab results. However, after comparing kind of those attitudes before the session and then after the sessions, kind of reassured me that these sessions might be having, some sort of impact on their clinical behavior as well as how they approach clinical management decisions. In this graph, while the knowledge of pathology did increase a little bit and confidence in their knowledge of pathology and the practice of pathology increased a little bit after these sessions, the biggest gains were really seen in their responses with respect to the knowledge of lab processes, as well as their overall comfort in contacting the labs and pathologists. And this to me was particularly impactful. Again, we don't have the greatest number of responses, particularly in the post-session setting, but to me, this change here was really important. Also assessed the likelihood that trainees would reach out to the lab here, and you can see that. And this was only obtained post-session, but the vast majority, the overwhelming majority of trainees indicated that they would definitely reach out to the lab more frequently. And in terms of how they value us and see us as potential clinical resources, there are very strong responses post-session indicating that they recognize that pathologists could be valuable clinical resources for them in terms of navigating patient care issues. I also provided, when looking at kind of those items assessing clinical behaviors, this is an example of one of those sessions. So provided them with a specific prompt, giving them a kind of patient situation, provided them a question focusing on what actions they would be most likely to perform and which actions they would not perform. This is a breakdown of one of those sessions, for one of those sessions, which is the surgical pathology and cytopathology session. While there's some trends that I can't really explain very well, with the limited data set that we have, one thing that I did want to point out in particular was the likelihood that these trainees would read the comment section for additional guidance. And it reassured me that pretty much all 5 of 5 respondents indicated that they would definitely read the comment section moving forward. As I mentioned, there have been some challenges in terms of obtaining data by survey. Obviously, in order to get survey data, you need participation in surveys. And I've obviously had some issues, especially in the post-session setting, getting those responses. And so there are a couple of reasons why I think that I might be having these issues, especially towards the end of the sessions. A lot of trainees want to get back onto the wards and get back to managing their patients. And so one thing that there are a couple of things that I thought about to improve the response rate in the post-session setting, including actually asking questions instead of giving them a survey, to kind of provide opportunities for real-time assessment and provision of feedback, and then potentially incentivizing survey completion as well. Outside of data collection, I've also noticed that there have been impacts on at least my interactions with the internal medicine team, including the chief residents and clinical trainees, particularly with respect to the interest in having pathologist representation at internal medicine, morbidity, and mortality conferences. So since I started having these conversations and giving these sessions to internal medicine, I myself have presented at 7 different morbidity and mortality conferences since May of 2022. I've also referred other faculty and other trainees, including fellows and residents, to present various cases and various topics at morbidity and mortality conferences. As Dr. Powell alluded to, I've also had a number of posters, case reports, and publications that have arisen from simply being a visible contact that the internal medicine trainees feel they can reach out to assist them in their own research. And I've also, directed some of these requests to other faculty and pathology trainees as well. And very recently, I've had some conversations with the internal medicine team indicating that they would be potentially interested in establishing additional interdisciplinary sessions and conferences. And so some of the things that I've taken away from my interactions with the internal medicine team is that they really are interested in learning more about who we are as pathologists and as clinical consultants and what we do. However, to continue with these sorts of sessions and build upon these interactions, consistent exposure, repeated exposure really is necessary, not only to develop these collaborative relationships, but also to maintain them, particularly in between services, clinical and diagnostic services that are historically, at least at this institution especially, very siloed. And this kind of degree to which these services are siloed, I've realized through interacting with trainees at other programs, is that while this kind of siloed nature of these services is generalized to a degree, it's very institution and also very service dependent. However, overall, increased exposure to and increasing understanding of pathology and clinical disciplines is really important in order to facilitate continued interactions between clinical and diagnostic services. Outside of this bridging program, there are a couple of different opportunities that I just wanted to touch on very briefly, just in the interest of time, to kind of further enhance exposure to pathology. Those could include, additional assignments, either self-directed or clerkship required opportunities for students to interact with pathologists. A shift to competency-based medical education could result in laboratory medicine and pathology being incorporated into those clinical competencies. And so other than pathobiology, and knowledge of laboratory systems and pathology services could potentially be assessed in CBME. And then, of course, expanding opportunities for medical trainees to interact with pathology is important. And we do have a lot of acting internships. And again, we do also have a lot of pathology electives for students to explore, which is great. And obviously, the number of faculty we have in the space the workspace availability we have kind of limits how many students can be rotating with us at a time. And so to me, that means that we need to explore additional opportunities too, to make sure that those opportunities for pathology exposure are available. In terms of how we can kind of change some of our GME approaches to kind of increase these opportunities and build these relationships. I think it's possible that we could have pathology trainees, if we work with the clinical and surgical services, potentially pathologists or pathology trainees could rotate with and round with these teams who are often already rounding on their patients with an interdisciplinary team. Could also expand opportunities with interdisciplinary lectures and conferences. And I'm working on right now developing an additional program which would allow trainees, especially non-pathology trainees, to schedule appointments with pathology trainees to review cases of interest purely for education, not for clinical management decisions. And especially if there are trainees that are involved in procuring specimens, that would potentially give them an opportunity as well to review the quality of their own work with respect to the quality and the quantity of specimen that they're able to provide. And finally, I just wanted to briefly touch on why teaching pathology, increasing pathology exposure matters. So this is a diagram from Tofik and colleagues published in 2022, kind of breaking down and kind of just showing the process of diagnosis for patients. And one of the things that stands out to me from this diagram is that, again, it's very siloed in terms of kind of primary care, initial evaluation, specimen procurement, and then specimen processing and analysis and reporting. And some of the issues, that we're facing and will continue to face in pathology and the process of diagnosis is that, especially between institutions and sometimes even within institutions, there's really not a standard, like one standardized process for ordering, for procuring specimens, or reporting findings. Often the diagnosing and treating physicians may not have any interactions with or any say on with respect to the ordering and procuring physicians' actions and what they put in the order and what tissue they actually end up collecting. And this can have a big impact on specimen handling and triaging, which can ultimately impact our ability to provide adequate results from ancillary studies. And then, of course, lack of integration of clinical and diagnostic services, as well as medical record systems, may result in loss of key information that could further help us in triaging specimen handling and making sure that we're getting the most out of that specimen for our clinical colleagues. And as the complexity of diagnostic testing continues to grow, a lot of these issues will not only persist, but there's also the growing need for collaboration between clinicians and pathologists to make sure that, the right tests are being ordered and the specimen is being used optimally for patients and patient diagnosis. And so it's really important, these clinical relationships are really important to establish now and to continue building in the future to help navigate the changing landscape of diagnostic medicine. And we need to increase our visibility. We need to be visible. We need to be a familiar resource to clinicians and clinical trainees. With respect to undergraduate medical education, and we do have this representation, thankfully, here at the U, but we do need to maintain a role in curriculum development to influence changes to make sure that pathology continues to be represented so that our future clinicians know about the lab and feel comfortable reaching out to our laboratory medicine and pathology colleagues. So just some of the key points for the talk today. The landscape of undergraduate medical education is changing. The landscape of diagnostic medicine is also changing. There have been a lot of structural changes that have obviously been made in undergraduate medical education that make it challenging for pathology to have a greater footprint in undergraduate medical education. And so, alternative strategies and kind of adjunct opportunities for pathology education and exposure, I think are not only potentially beneficial, but in many instances will be necessary to make sure that our clinical colleagues and future clinicians really understand how we can be of service to them. This is a list of my references. Last but not least, I want to thank, in particular, Dr. Powell and Dr. Aries. They have been fabulous mentors that have helped me on my journey and to medical education. And I want to give a big thanks as well to the internal medicine team that I've worked with and to all of my faculty mentors here that have really made my residency education a wonderful opportunity. I also want to thank my co-chief, Dr. Mohammed Al-Utaibi. He has really made being a chief as easy as it could possibly be. And I also want to thank my fellow residents that have also made this my learning experiences just a wonderful experience, and I really appreciate their work and their support and their guidance. And my clinical friends and colleagues, including my sister, also wanted to thank. I know kind of running a little bit over time, but I want to thank you for your time and attention today. And I would be happy to take any questions or comments.
Oh, thank you so much, Megan. That was just wonderful. Any questions, John?
Megan, that was fantastic. Thank you so much for doing that. I'm going to be very brief. What you were talking about reminded me very frequently of Mike Lapasada's diagnostic management teams, and we don't talk much about that. But the question I want to ask you actually relates to several of your slides, which actually brought up this question. I have, for many, many years, wondered why we continue to make a distinction between anatomic and clinical pathology. And I'd like to get your views on that.
Oh, it's a loaded question, Dr. Crossan. I mean, I think there is, to a degree in terms of how we approach the specimen analysis and what the specimen is. I think there is somewhat of a distinction, obviously, between like the solid and the liquid tissues. But ultimately, in terms of the role of the pathologist as a clinician and as a supporting member of the clinical team, I think it's a fairly universal role. And so that shouldn't affect, how you're interacting and how you can impact clinical management from a standpoint of whether you're in anatomic or clinical pathology. And also, as I point out on the kind of the spectrum of pathology slide, it really is a spectrum. And so it's, we may consider them kind of as distinct anatomic and clinical pathology, but really kind of the process of approaching diagnosis in terms of understanding your patient, understanding other diagnostic information that we have about the patient, the clinical context in which the patient is presenting, all of these are very similar between anatomic pathology and clinical pathology with respect to how we kind of approach our process of diagnosis and how we convey that information to clinicians. So although the distinction may be more artificial than not, there are a lot of similarities and overlap, I think. And there's a lot of interdependency I would say, between anatomic and clinical pathology. Even if it's not necessarily always called out or focused on, you can't really have one without the other. And that's something that I try to convey to the clinical trainees during these sessions.
Thank you, Megan. Very good job.
Thanks, Dr. Crossan.
Claudia, did you have a question?
Very quickly, if there's time. Megan, great talk. I'm a big fan of the work that you're doing. Have you been working with Dr. Powell and Aries on sustainability of this program?
Yes, and actually, I had a recent conversation with Dr. Aries, and especially as I'm getting obviously closer to the end of my residency, I will thankfully be staying on for a humanopathology fellowship next year. So I'm planning at least to continue doing some of this work and expanding what I can of the project. But I've started talking to Dr. Aries in particular about potential alternatives for kind of ensuring the longevity of this program. So I've I'm considering and have been trying to recruit residents into kind of running this program and working with this program to keep it like resident based. But one of the suggestions that Dr. Aries had was to incorporate this essentially into a longitudinal exposure to pathology in medical school curriculum. And potentially kind of requiring these lectures to be given either by residents or pathology faculty as a component of the medical school, medical student curriculum. So that's something that I had not personally thought, but I think is particularly intriguing. And so I'm looking forward to discussing that a little bit more with him.
Thank you.
And go ahead, Pari.
That was great, Megan. Thank you so much for addressing this critical need. I just have a quick comment. Another potential target audience for these kind of presentations could be the new faculty who come into the university.
Sure.
It could be incorporated with the new faculty orientation lectures.
I honestly did not think about that, but I think that is an excellent suggestion. And I'd be happy to talk about that more with you as well. Because I agree. I think it would be a great way to kind of standardize introduction, especially to our laboratory services and our pathology services as well.
That's great. So lots more to do, Megan.
Yes. Yes. Lots of work to do.
Well, thank you so much. And it was a wonderful presentation. Thanks, everybody, for joining.
Have a good day, everyone. Thank you.
Take care, everyone.